Thank you very much, anyway. That was a great talk, and I want to thank all three of our speakers for wonderful talks addressing these key issues. And what I'd like to do now is open up to the roundtable. We've had some fantastic questions, and we'll try to get to as many as possible in the next 20 minutes. And what I'd like to open up with a lot of questions on the switching when you don't have resistance testing. I think we highlighted the issues of switching, both in adults and pediatrics, the many drugs we have, but the challenges that we have sometimes when we can't have a resistance test. So what's a clinician to do in a setting when you're in an area where you don't have access to resistance testing after first line? What would be your approach? So maybe Kumar, we'll start, we'll go around the table.
Sure. Thank you, Jonathan. This is a very critical question for all everyday practicing clinicians when a patient comes to you with a treatment failure. I think before I move into the treatment failure, I think we all know that in our regions, our baseline NNRTA resistance has been going up. So I think our preferred therapy should be a TLD. So I think if you keep on doing TLE, tenofovir, lamivudine, and efavirenz NNRTA, the chance of getting failure will be very quicker because we already have a baseline resistance of more than 10%, which will also cause a quicker failure to other regimens like 3DC and tenofovir. So you're bound to fail everything quickly. I think initiating on TLD will be the wisest choice so that our duration and our potency of the first line therapy will be good. But now to these questions on what will be the best regimen you'll be switched to when in the absence of resistant testing in a resource limited setting. And I assume most of you have been switching from a regimen of TLE or AZT and 3DC and nevirapine in some of those regions. These are those drugs widely been used for a decade, and now they have been failing to switch to. So ideally, our treatment guidelines recommended. So you switch from one NRTI and optimize to another NRTA which you have not used. For example, when you have been using tenofovir, you change them to AZT. If you have used AZT, you change them to tenofovir because of the earlier theory that when someone fails with tenofovir mutations, AZT will be hypersusceptible, and also someone failing AZT, tenofovir could be a better choice. And you change from efavirenz to a non-NNRTI, either to a boosted PI or to a DTG. But the current guidelines is very clearly recommend rather than the PI, dolutegravir should be the preferred choice because the potence we are not used as a first line. Then you may ask a question again: are you going to still optimize the NRTI from tenofovir to AZT or AZT to tenofovir? Now we have been doing this till the last WHO guidelines in 2019. But on the other hand, many of us, as I showed in the presentation, that are not very comfortable to use AZT as a second line because of the toxicities and twice dailies. But on the other hand, all the study shows very potent, but safety is very important, for our patients who are taking these drugs on a long run. And following these two very good presentations, which have been published very recently, which I showed in my talk, the NADIA study, where I've shown by recycling tenofovir, even if they have resistance, still have got a lot of NRT activity. Now, this we have shown in earlier studies, in the second line study, in the EARNEST study, and as well as in the ACTG 5273, all have shown, NRTA still work when we, recycle. But now this NADIA study very clearly have shown that recycling, despite they have tenofovir resistance, moving them to tenofovir, lamivudine, and dolutegravir would be a good choice. Hence, to this question, I think in our resource limited setting, someone fails TLE, based on these evidence, we can safely switch them to TLD. But on the other hand, I'd also strongly recommend these clinicians do a viral load sooner, especially in people who are switched to second line by within 3 months after switching, to know that they are virologically suppressed. So you're doubly sure they are well suppressed and you're very comfortable in continuing those therapies.
No, I think that makes good sense. I guess the one thing I was, I don't want to say concerned, but a little raised an eyebrow. There was some resistance on those patients who failed the dolutegravir, something that, we almost have not seen. We've sort of forgot about the option, but it seemed there were some patients who failed and had then dolutegravir resistance. You think this is going to be a problem, or that's something, considering the small numbers, not of great concern?
Yeah, I think ideal scenario will be to do a good resistant testing and switch, how you do in the research-rich settings. But in in a public health setting, in a resource-limited setting where genotyping is not widely being available, only a certain referral centers do that, and you have a very large number of patients in your program, what do you do? I think in a public health setting, I think anticipate what those possible resistance mutations from those earlier published studies and switch. And also the recently published study on Nadia and the revamp presentation very clearly shows that recycling really helps in the public health setting.
Thank you. I think also, as you said in your study and here, doing a viral load early is important to really reduce the chance of resistance. That's something that a tool you do have that you can use quickly and efficiently, not to forget to do as soon as possible.
Yes.
Thank you.
On the other hand, we have any point of care resistant testing available, which will be cheaper, where everybody can do that. Now, I think I will use this as a clinician, either in a research-rich setting or in a research-limited setting, just to it. And so, since we don't have the technology, I think we need to go with these public health switching strategies.
Thank you, Kumar. Kia, also your thoughts on this, on the switch, and as we mentioned in the setting where you don't have the resistance test, and also your thoughts on the any resistance in the NIDA study. Kia, please. Kia, did we lose you? I think maybe Kia got dropped off, so maybe I'll move Tanya away. Your thoughts on this also in pediatrics? Yes, thank you.
Yeah, in pediatrics, I think the first thing that when you have failed regimen, in pediatrics, there are several issues related, especially in young infants. That under 3 years, we recommended lopinavir. And the lopinavir oral solution itself, they have some struggle of taking medicine. So whenever we see the failure in pediatrics, I think I would say roughly 50% is related to formulation or related family structure. So in that case, the resistance is not an issue. It's just the issue of how to provide treatment for pediatrics. So in that one, I believe that when we change to the dolutegravir, it will solve the problem. So, but for someone who might have failing and have drug resistance, to me, I think change from boosted PI to the dolutegravir, mostly because of the oral solution lopinavir restriction. And also when you fail boosted PI, usually NRTI resistance is not that high. So I think for young infants that taking lopinavir, switch to the dolutegravir shouldn't be a problem. But for older children who maybe use ephedrine and change to the dolutegravir, in terms of public health approach, I still believe that the dolutegravir plus tenofovir, which K65 are maybe not that high in pediatrics population. So it would be okay in resource limited settings, not having viral load testing, and then switch to the dolutegravir based regimen and support idea of Kumar that if possible, we can use viral load monitoring at 3 months, because it can quickly detect if whether they can solve the problem of adherence and taking medicine. And also with the dolutegravir, I do believe that within 8 weeks with proper ART adherence, it will be able to bring down viral load. And then you have a checkpoint at around 3 to 4 months after switch. And don't worry, just go to change the regimen, because it would be benefit in terms of more palatable and more easily to provide to pediatrics and children population.
And I think that sounds like a very reasonable strategy. Thank you, Tanya Wei. Kia, we lost you for a second there, and we'd like to hear your input. We're discussing the switch from first to second line when you don't have a resistance test, and some of the consideration, the data that have been mentioned. Your thoughts on this?
Yeah, I like, sorry, I disconnect for a while. So I like to support both panels, so Kumar and Tanjavi. I think it's clearly that for the public health setting, drug resistant testing, when we have dolutegravir best regimen available, I think it's that justifiable. But what I like to raise some of the issue is that I think the first thing is we love to see more longer data, durable data of Nadia study. So 1 year, you look at even the naive population, you have a 90% plus of undetectable, and then you go another year, you have getting worse and worse and worse, right? 5 to 10% drop of the success rate. So I think it would be very important to look at that durable data. Secondly, we learned a lot that you switch someone when the baseline CD4 too low and the high viral load, more than 100,000 copies. So that also a high risk. It means that this individual has been failed so long before you switch. So you have a chance of lot of mutation accumulated. So I think that type of thing. And I also like to support Kumar that we love to see the whole world to switch from efavirenz-based regimen to dolutegravir regimen. And at that time, maybe we can also discuss whether we really need viral load testing or not. So because, and then you can do some of them. So again, it's a lot of things that, remember that we, in some of setting, even in Asia, what I heard is that viral load testing is not available. It's only less than 15% of people accessible to viral load. So I mean, don't even talking about drug resistant testing. Yeah. So I think that I think DTG based regimen should be the wrong term to go.
Yeah.
Long way to go. Yeah.
Jonathan, can I add here something? Yeah.
Yes,
Yep.
please, Kumar.
So thank you, Keith, for saying that. I think we should right time move. Everyone should go to the universal TLD. I can tell you, as you know, that my country now going through one of the roughest, COVID pandemic now. Now we have switched all those patients to TLD from the TLE, even some years back, 3-4 years back, because we had access to generic TLD in our clinic, and we are one of those first to do that. This really saved, our patients, because they had a very limited access to come to the clinic to see them, limited access to come to the clinic to do all the routine CD4 and viral load. So what we have been doing is we did the teleconsultations the last 1 year on all these patients doing well or anything, and make sure that they adhere to the drugs. We even send these medications to courier to them, to their houses, or through the post office. And also in India, we also had this 3-month supply in one bottle, what is called multi-month prescription. I think this all really helped. But if those patients would have been on TLE, even we also would not have been very unsure that what will happen to this patient without good monitoring. So now, really, and I think TLD, as you rightly said, such a robust regimen. It's time that everyone should move forward to that. And also, I feel if you are on TLD as a first line, even if they fail, probably not because of resistant mutation. It's mostly because they are not taking the medicine. So
not taking.
That's another way where improving the adherence will help. I think it will be a good answer for our resource limited set.
And I think these are important points. I think the importance of viral load, and we have an excellent question here, which maybe we can address if we have time, on doing pooled viral load. We are actually doing pooled viral load, which makes it, of course, much easier to do frequently and more cost effective. And I think perhaps we misled people into thinking that you really need to do resistance testing to treat your patients well. I think, Kumar, as you said before, if you have it, you should certainly do it. But I think we know that if you, with the treatment options we have and with aggressive viral load, you often can skip it. And I think, aside, I think for, if you're not using first line NRTIs, but move to TLD, I think you can really usually save the resistance testing for second line failures. And hopefully, if everyone's getting TLD and well motivated, there won't be a lot of those. So I think this is an important issue. I think also, the fact that doing resistance testing is nice, but for most of our patients, not absolutely required, I think, is something, because perhaps folks think they can't treat their patients well if they don't have that. And I think that's perhaps, and again, I think this issue of pooled viral load and other strategies. And of course, I think these assays can be made less expensive. So we can get to them more quickly. Maybe, anyway, a question also, I think you were alluding to this on adherence. As children go through those stages, as children when they're caregivers providing, but then they become teenagers where they have to take it themselves.
Yeah.
So,
Yeah.
and maybe throw into that also, the question of other healthcare providers, nurses and social workers, how do we get our hands around getting the patients to take the drug at the different ages?
I think in pediatrics, there are the word of developmental milestone that go through along the way. I think many people have families, and we know that for children, when they're a teenager, 12, 13, it's the time that we need to involve them into care. We start to disclose about HIV. We allow them to integrate their care, not provided by care provider, but we invite adolescents to taking care of themselves. So I think TLD is a forgiving regimen that will be benefit for adolescents, because if you take efavirenz and adolescents have sometimes that they have some upset from school or have some difference from friends and they don't take medicine for a while, efavirenz might cause resistance, but TLD is more user-friendly and have forgiving for adolescents. So I hope that with what dolutegravir will help adolescents to get through that developmental phase, especially during 13 to 18, that usually we are not treat them like a child to dot them because it's not proper. They need to understand about HIV, taking care of themselves. So I hope that TLD will also have a benefit, special benefit for during the adolescent and young adult period.
Thank you, Tanya. We're getting close. Kia, we did have a lot of questions on the issue. These switches you mentioned, there are lots of reasons that patients want to switch. So you certainly have a lot of experience. What is commonly the reason that patients are switched? First-line patients are suppressed. Why, in your experience, do they need to switch? And does it usually come from the doctor or from the patient?
From patients, what matter to adolescent is smaller pill size. If we can do smaller pill size, reduce from twice daily to once daily, and also to saying that they have less problem on neural like efavirenz. Some kids still have struggle at attention or neural complications. So all of this is helpful, but the most important thing that if we can say that it's reduced to one pill, smaller size, adolescent will take it.
Yeah, I think.
Thank you.
Yeah, Jonathan,
yes.
for the adult, I think the reason of switch, I believe, if they remain viral-suppressed, is either the side effects and also maybe drug interaction. But I think side effects is more common. Yeah.
We're getting to the end. Lots of questions coming in, and lots of questions. All the talks were fantastic. I do also think, we've been mentioning the study in Africa. There were some of the patients who failed the second line who did get resistance to dolutegravir. So I think, Kia, as you mentioned, I think all of us are involved in resistance. We have to monitor resistance, even if we don't take it for individual patients. I think the WHO and many of the folks here, the faculty, were involved in that. Even if you're not doing it for the individual patient, we have to know in our country. And I think, Kumar, Kia, you guys mentioned those key data, and those are data that I think we need to continue to generate. So we're getting very near the end. I don't want to take up time from the break. I want to thank each of you. The talks were fantastic. I also want to thank the folks who on the roundtable questions that were coming in. We have many more. I do want to leave each of you just 1 minute to give your bottom line take-home message to our audience, maybe a key concept to leave them with. Kia.
Okay, I think during this pandemic of COVID-19, I think we start seeing people lost to follow-up because of have trouble, either to earn money or trouble to travel. So I think we have to find any mean to support them. And again, probably, like Kumar said, probably have to switch them to TLD or tab-based dolutegravir regimen quickly after they have lost to follow-up. The second point I'd like to make is that don't leave your patient fail too long. I mean, once you detect the viral load, turn to be detectable, make sure that you assess the cause of failure. If it's mainly a non-compliant, you might restart it and then recheck the viral load again. But don't let it fail too long. Otherwise, we're going to lose a lot of opportunity. Thank you.
Yes, good point. Thank you very much, Kia. Kumar.
Right. I echo whatever Kit said. These are very important points. But on the other hand, we also should not be complacent stating that DTG won't develop a resistance. So I think it's also important, as Jonathan rightly said, we should monitor this over a period of time. But it's not like efavirenz, but on the much more potent, I think we need to be very careful, on using these regimens when they have been failing virologically, whether they have been developing resistance. But on the other hand, very important carry-on message, I think I'll give the practicing clinicians in this pandemic is, ask your patients to get vaccinated for COVID. I think that's very, very important. In fact, what I'm seeing in my patient population is people who receive 2 doses, even if they develop a COVID, they have very mild disease in my patient population. People who are not received, HIV itself is a major cofactor where they may need to be hospitalized sometime in ICU. I think that's very important. We are not sure that how long this COVID is going to move on. So I think we need to advise our patients appropriately. Thank you.
Thank you very much, Kumar. Tanya, final words?
I think the concept is don't leave someone behind. And I think prime time for pediatrics and children it's right now because we have more formulations for pediatrics. But I understand that sometimes pediatrician or the clinic is afraid for the change. But don't afraid, just change to integrase inhibitors. It can help to solve a lot of problems. And the second one is that don't give up for pediatrics and children, because even though if you start with the first line and you consider that dolutegravir might be second line, but I do believe that they can have a normal life expectancy. And the third line or fourth line will come up. Don't afraid that someone feel like you're going to use up the dolutegravir and what's going to be in the horizon. But I do believe that they need it right now for integrase inhibitors to solve many problems, even first line or second line. Don't afraid. And I do believe that they will have normal life expectancy.
Wonderful. Well, let me thank you all again. We're going to have to close just due to time. We have great questions. It was a real honor to chair this session with 3 faculty. I think that the talks were great and the discussion was great. So I'll hand it back to the session organizers. I think there's a 10-minute break, or now it's maybe an 8-minute break. The next session starts at 20 before. And let me thank you, everyone, and say goodbye.
Thank you.
Thank you, Jonathan. Thank you, everyone. Bye-bye.